Hi, everyone. Um, this is Mary Ann Joyce. We're going to start in a minute or two. We just want to have a few more people hop on. Okay, I'm going to start just because we are going to try and get this done in 15 minutes. Welcome to our monthly Lunchtime Learning Series. I'm Mary Ann Joyce, Physician Liaison for OHC, and today's topic is Targeting Pain Relief, Exploring Osteoarthritis and Radiation Therapy, presented by Dr. Bertke. Dr. Bertke is a radiation oncologist who specializes in lung cancer, breast cancer, head and neck cancer, prostate cancer, and metastatic lesions. And his area of special interest is stereotactic body radiation therapy, SBRT, for lung, bone, liver, and adrenal lesions. He's been with OHC 5 years, is that right?
That's right.
5 years. And a fun fact, Dr. Bertke has a Bachelor of Science and a Master's of Science in Engineering. And before he went to medical school, and he worked as an aircraft engineer at GE and as an automotive engineer at Chrysler in Detroit, Michigan. So, and here we go. Dr. Bertke, go right ahead.
Yeah, thanks very much.
Sure.
So we're going to talk today about osteoarthritis and using radiation to treat it. Usually I'm talking to people about treating malignancies with radiation, but today we're going to explore a benign indication that we've been using more and more with a lot of success. There are traditional indications for radiation and benign conditions that we've treated, mostly proliferative things in America, like heterotopic ossification or keloids. But more and more, we're looking at treating inflammatory conditions like osteoarthritis or plantar fasciitis with radiation as well. Now, osteoarthritis, obviously, it's a very common thing. There's an estimated 50% lifetime risk of developing osteoarthritis, and over 30 million people currently in America that are suffering from or dealing with osteoarthritis in one form or another. And it can strike any joint in the body. Hands are very common, even more so in women, and knees are quite common across the sexes. Now, the traditional course of treatment for osteoarthritis kind of starts with, less pharmacologic and less invasive procedures like, exercise, weight loss, things like that. And then escalates into topical pain relievers and then systemic pain relievers, like Advil and ibuprofen, things like that. And then it usually escalates into joint injections and then a joint replacement, kind of on the classic orthopedic paradigm of treatment. I think the big thing to point out is that, even some of the things like anti-inflammatories or NSAIDs aren't without risk. And, in older patients, there's an excess risk of about 7 in 1,000 non-fatal cardiovascular events per year and 2 in 1,000 fatal cardiovascular events per year that can be at least partially attributed to NSAID use. And a fourfold increase in the risk of gastrointestinal bleeding. So even some of the things that we consider benign, have some risk of side effects. Now, with radiation, it's something that's actually been very commonly used throughout the world for osteoarthritis for some time. In Germany, in fact, about a third of all radiation treatments that are delivered for benign indications like osteoarthritis. In the US, there's been increasing utilization, especially in recent years, as there's been more data published and more kind of interest nationally as well as locally here at OHC. So the first question, obviously, does it work? And the literature says definitely yes, it does. Pain response rates are on the order of 60 to 90%. We usually quote patients around 70 or 75%, and that's about the response rate that we've seen in our clinic. And it's quite effective, and we usually measure pain on a 10-point scale, and the average reduction in pain is around 3 to 5 points on a scale of 1 to 10. We can retreat patients, kind of basically do it again as early as 12 weeks later, because a lot of these treatments, just like in joint injection or things like that, they're not permanent. Just to cite some of the big studies that have been done in this area, there's a large German study that showed about a 2 out of 3 response rate at 8 weeks. And even people that required a retreatment, over 60% of those had a good response to retreatment as well. In a large prospective study looking at how much pain reduction there was, it was basically a reduction from 8 to 3 at 6 months post radiation. So it's even more durable than we usually think of as the length of time that a joint injection would work. And then if we know it does work, we want to ask, how does it work? And there are many different ways that radiation can be basically anti-inflammatory. This slide kind of points out a lot of different potential pathways that can be utilized. The important thing to note is that the very low doses that we use are the key to being anti-inflammatory, because radiation at higher doses, the kinds of doses that we use to kill tumors, can actually be pro-inflammatory. But with very small amounts of radiation, it can have various effects in the cell. To kind of point out a couple, I want to look at basically the effect it has on cytokines, which are basically substances that are secreted that are inflammatory. And radiation can cause decreased expression of pro-inflammatory cytokines, so these substances that are going to increase the inflammatory cycle. And it can also increase anti-inflammatory substances that are being created to kind of counterbalance inflammation that's already there. When we're looking at reactive oxygen species, which are basically another form of basically continued irritation and damage within an inflamed joint in somebody suffering from osteoarthritis, radiation can actually reduce the production of those reactive oxygen species and kind of turn down the effect of macrophages that are causing kind of excess damage and destruction within the cell or within the joint. When we think about treatments, especially radiation, we're thinking about risk versus benefit. So we need to look at what potential adverse effects or drawbacks there are to treatment. And the interesting thing is, with this low of a dose of radiation, there are virtually no adverse effects or downsides to treatment. The radiation doses that we use are below the threshold that we see things like skin irritation or tissue damage. And in those large studies, like I mentioned before, there was a one case out of 1,000 patients that had mild temporary skin redness that might have been due to the radiation. So very low risk of side effects, and that's typically what we would tell patients as well. There's no impact on future surgical procedures, and it's not really a high enough dose of radiation to cause fibrosis or scar tissue that maybe a surgeon would be worried about if they had to do a joint replacement in the future. Malignancy risk, or the risk of causing a cancer with radiation, is an important thing to talk about and consider with any kind of radiation, especially for a benign condition like this. But the human body is really well adapted to repair from low levels of radiation. We're exposed to radiation every day in the form of cosmic radiation from the sun, radiation from the earth like radon. And our bodies can kind of repair small amounts of radiation exposure pretty continually. The effective dose exposure for treating low dose radiation to, say, a joint or as a knee joint or the hands is similar to a non-contrasted CT of the abdomen and pelvis. The malignancy risk there's disagreement in the radiation field as to whether there truly is a possibility of causing a cancer with these low doses of radiation. We basically have different models that can predict risk of cancer being caused by radiation, and there are well-known risks in higher doses and higher dose levels. And there are cases that have been reported, and you can kind of see what the expected rate is. As you go down and have lower and lower doses, you have less and less verified effects. And in the range of radiation dose exposure that we use for low dose radiation for arthritis, we're kind of below the range where there's ever been a reported case or known cancer being caused by radiation. And it's something where it's a possibility that there's a threshold, meaning that you have to get a certain amount of radiation before there's even a risk of causing a cancer with radiation, mostly because of your body's own repair mechanisms, like we mentioned before. So where does radiation fit? Basically, if somebody has already tried non-pharmacologic interventions like weight loss, and they've maybe tried some topical pain relievers, and they're starting to use anti-inflammatories or over-the-counter medications like that, then we can start considering low-dose radiation. Some of our patients have been using Advil or Aleve for a while. Some of them have even gone to the get multiple joint injections and still have issues that are persisting. But typically it's in that range that we start to consider utilizing radiation. Ideally, we're treating patients that are older just because we want to make sure that we are minimizing risk of radiation to patients that are younger, even though there isn't quite any documented evidence of causing a malignancy or problems. And most osteoarthritis is in older patients as well, just with normal wear and tear with age. So we deliver 3 gray, which, knowing something about radiation, traditional radiation for prostate cancer is about 80 gray. So it's much, much, much less radiation than traditional radiation treatments. Typically, we're delivering them in between 5 and 8 treatments over the course of 2 to 3 weeks. We treat the entire joint because we're treating basically all of the inflammatory effects that are within that joint area. We have different setups depending on where the patient is being treated so that we can immobilize that area. And a lot of this is kind of custom patient to patient, depending on how they can lay for treatment and what joint that we're trying to target. Just a quick note on plantar fasciitis. There's also strong data showing benefit for radiation, potentially even stronger than the osteoarthritis data, with a similar thought process behind it for decreasing inflammation and a similar type of treatment arrangement. This is showing a pathway that I helped develop with US Oncology and being used throughout the network. And our work over the past few years with osteoarthritis actually puts us at the top of the network in terms of number of patients being treated and how rapidly we've adopted this new form of treatment. There's a handout that we've been given primary providers and different specialists that are referring to us to kind of summarize a lot of what I spoke about today. And it wouldn't be a medical talk without at least mentioning insurance, but this is covered by Medicare and commercial insurers. We've not had any issues with getting it approved. And it's specifically called out as being approved in some of the guidelines for some of the insurance benefit managers like Evacor. So with that, I think we're at the 15-minute mark, so I'll wrap up. But if there are any questions, I'm happy to answer. And for more information, you can certainly reach out anytime. Dan, you have a question?
Yeah, what areas is this used on? Primarily like knees and extremities, or do you treat the back
Yeah,
or
so
neck?
it's primarily extremities. So the majority of our treatments have been knee, hip, and hands, but we've also treated elbows, shoulders, and we have treated some spines. Now, spine treatment is a little bit trickier because there's a lot more that goes on inside of the spine in terms of how the joint works and the discs and things like that versus the joints and the extremities. So sometimes the pain is a lot more multifactorial rather than strictly osteoarthritis. But I personally have seen good response to treatment of the spine. It's just not kind of the bread and butter. Let's see. Who else has a hand raised?
This is Roseanne. I do. I noticed on
Yeah.
the front page that it says for plantar fasciitis as well. Is that
Mhm.
right?
That's right.
Oh my God. My husband's been suffering for that for 4 years. So I will bow down to you. You can fix him. Do you need a referral from his primary care doctor or can it be self-referred?
No, we've had a lot of patients that are self-referred because honestly, the majority of patients that we've had have been, probably word of mouth from previous patients that we've treated. So, we treat somebody and then all of a sudden all their friends want to come see us. So,
Okay.
you don't need a referral to come in.
Okay. Fantastic. Thank you.
I think there was a chat question that came in, but it popped up and now I don't see it. Is anybody, let's see.
Yeah, it says, are there any contraindications patients who shouldn't get this due to any comorbidities?
Not really. We want to make sure that somebody doesn't have rheumatoid arthritis or psoriatic arthritis that's causing the issues. We want it to be true osteoarthritis, just because the kind of inflammatory cascade is a little bit different with those diseases. We typically prefer patients that are older than 45, and the majority of our patients have been 60 and older, just by the nature of how osteoarthritis usually strikes. But there's nothing specific that we need to avoid. Even patients with some skin conditions doesn't disqualify them just because the low dose is well below the thresholds that we usually see problems with.
I have one more question, and I probably should know this being over new patient scheduling, but are you doing this at all locations?
We are. Now, sometimes it depends on the treatment load at a certain site, because to be perfectly honest, we don't want osteoarthritis to take the spot of somebody needing cancer treatment to get done quicker. So sometimes, a patient might live closer to one location, but might be offered treatment a little bit further from home versus waiting a little bit longer, just so that we're not bumping a spot from a cancer patient that needs to start quickly. Um, so that's most of what goes into the scheduling aspect of it. Any other questions? Let's see. So yeah, so I would not want to treat through a pacemaker. There was a question that came up about a pacemaker in the shoulder area. Um, we wouldn't treat through the pacemaker, but typically the shoulder joint would be clear of where the actual pacemaker is placed. And when we're doing radiation treatment planning, we would model out the pacemaker and make sure that was staying well under our radiation, doses. Now, typically the pacemaker manufacturer guidelines say to keep the radiation dose there under about 2 gray. The prescription dose is only a slightly bit higher than that for low dose radiation. So we're already, very low as long as we're not passing radiation through it, and it's not overlying the joint. It's actually not really an issue. Any other questions that I missed? Looking at the chat now. That's it. Well, thank you everyone for coming. Feel free to reach out to me or schedule an appointment or refer people in. Always happy to answer questions if you think of something off topic later on.
Thank you so much, Dr. Bertke.
Thank you.
This has been a recorded presentation, so if I will send it out to all of the people that registered.
Great.
Thanks
Thanks very
again.
much.
Bye.